Okay, thank you very much, Sparrows and Horst, and good morning, ladies and gentlemen. So what I'll discuss is the role of endoscopy in making a diagnosis of Barrett's esophagus and a look into some techniques to improve our diagnosis of dysplasia and early adenocarcinoma in patients with Barrett's esophagus. So this is a late-stage adenocarcinoma. This is a patient who had chronic refractory GERD, like George's presentation, and eventually developed dysphagia and weight loss and was diagnosed with a T3N1 adenocarcinoma. And these are, unfortunately, the majority of the cancers that we end up seeing are patients who develop dysphagia and adenocarcinoma. The reason this is important is because just like reflux symptoms, the incidence of adenocarcinoma of the esophagus is increasing. These are data from SEER in the United States, which show that squamous cell cancer of the esophagus is decreasing in incidence, and during that same time period, adenocarcinoma has increased in incidence, and this is true not just for the United States, but for the majority of Europe and Australia as well. Even in Asia, where squamous cell is still the predominant type of cancer, adenocarcinoma is increasing significantly, although the proportion of patients is still pretty small when you look at it. So when you look at the role of endoscopy in this patient population, the first is recognition of Barrett's, that the patient has Barrett's esophagus. And the second is then finding dysplasia and adenocarcinoma in these patients. Endoscopically, this is the most important landmark, which is the top of the gastric folds or the gastroesophageal junction. And anatomically, everything above this is the distal esophagus, and anything below this is the gastric cardia. So make sure that when you take biopsies, you're actually taking biopsies above this landmark and not below this landmark, and that may lead to a confusion in the diagnosis. Currently, the contemporary definition is to identify the landmarks, diagnose the columnar-lined esophagus, and take biopsies which reveal goblet cells and specialized intestinal metaplasia. Once you've made this diagnosis, you should grade it using the validated Prague criteria, and these were developed by the International Working Group for the Classification of Esophagitis, the same group that developed the Los Angeles classification. And this is based again on landmarks, starting with the gastroesophageal junction. You measure the circumferential columnar-lined esophagus, which will give you the circumferential value, and then you measure the most proximal tongue of columnar-lined esophagus to the gastroesophageal junction, which will give you the M value. And so this helps you in diagnosing and grading Barrett's esophagus based on the Prague C&M criteria as to what the C value is and what the M value is. Equally important is knowing what's not Barrett's esophagus. So we spend time making a diagnosis of Barrett's, but what's not Barrett's esophagus is shown here is that this is actually a hiatus hernia and not Barrett's esophagus. If you remove air from the distal esophagus, what you see is that the top of the gastric folds and the squamocolumnar junction are at the very same level. You may see some irregularity of the Z line right here, and the question always is, should you biopsy that? And the short answer is no, because this actually would be a normal squamocolumnar junction, maybe with some irregularity. The kappa value endoscopically, that this is Barrett's, is very low. And this was also shown when we did the exercise of the Prague C&M classification, that if you have a length of less than 1 centimeter, we are very poor at endoscopists as reproducing this abnormality. You could take biopsies here and find intestinal metaplasia, but this truly is not esophageal intestinal metaplasia, but probably cardia-intestinal metaplasia. And there are a few studies which have shown that if you follow these patients with cardia or GE junction intestinal metaplasia, very few of these will progress to dysplasia, if at all, and virtually none of these patients in prospective series has progressed to cancer. So equally important is mislabeling a patient with Barrett's esophagus, and you should try to avoid biopsying a normal squamocolumnar junction or an irregular Z-line. How about diagnosing dysplasia and adenocarcinoma? And this is the spectrum that you see, is going from the left to the right, is intestinal metaplasia, which goes through low-grade dysplasia, high-grade dysplasia, and adenocarcinoma. And the spectrum of this diagnosis is equally important because we rely on our pathologists to make this diagnosis, which is problematic. So low-grade is the one with the maximum problems, and this is the enigma. This is a study now from several years ago done amongst community pathologists in the United States. When they took a diagnosis of low-grade dysplasia as a gold standard by expert pathologists, which we can also argue how good they were, and then they sent it to 20 community pathologists in the United States, and what they found was a whole slew of diagnoses, from low-grade being the minority to high-grade to moderate dysplasia, which is not a term being used these days, and 25% with non-dysplastic. So the diagnosis is all over the place. At DDW this year, what we decided to do is try to get some of our Cleveland Clinic pathologists involved in this to see whether we could revisit these criteria. We had a consensus meeting of these expert pathologists from Cleveland Clinic. We asked them to revisit the low-grade dysplasia criteria, come up with some new criteria. They agreed on these criteria. And what they thought was that the most problematic part was the inflammatory component within low-grade dysplasia. So they said that, okay, we'll try to make a diagnosis by classifying this as low-grade with predominant inflammation, or low-grade, which is predominant neoplastic. And also how confident they were in making this diagnosis, because we use this in medicine all the time. When you see something abnormal on endoscopy, you try to think how confident you are whether this is truly a polyp or is this a lymphoid follicle in the colon near the terminal ileum or not. So we decided to give our pathologists this option as well. We had 79 slides reviewed by them, and to our disappointment, even after revising the criteria, the pathologists were worse than a coin toss in making the diagnosis. When we subdivided it into inflammatory and dysplastic, they really didn't do any better, and actually the kappa values significantly fell down to really poor levels, which tell us that even amongst expert pathologists, this is a moving target, and we really can't define the disease, so finding a treatment becomes difficult when you don't know what the disease is that you're looking at. The only thing that helped was a little bit of this high confidence in which when the pathologists looked at a slide and thought that they were a little bit more confident in making this diagnosis, their kappa value improved to 0.3, which is still not that great, but at least this was the only sign that we could see of improvement in making this diagnosis. How about biopsies? What we use is called the Seattle protocol, or the 4-quadrant biopsies every 2 centimeters. This is what's recommended to make a diagnosis of dysplasia. And this study looked at how many physicians in the United States actually follow this protocol. And what they found was that it was only 50%. Only half of the US endoscopists spent time taking biopsies from the esophagus the way it's recommended. And you can argue that, is this really necessary? And at least in this study, if you did not follow the 4-quadrant biopsies every 2 centimeter protocol, you were more likely to miss dysplasia, whether it was low grade, high grade, or cancer. So we actually don't follow the guidelines or the protocols which are recommended by the societies to diagnose dysplasia and cancer in Barrett's esophagus. One problem in Barrett's is to be sampling a larger tissue area. And one way to do it is to be able to do it by using a cytology brush. And this has been done through ages, but this is a new technique called the WATS technique. And what this does is that it uses a more abrasive brush. The best way to do this is to open the brush, and then instead of using and moving the brush back and forth, you fix the brush and you use your endoscope and move that back and forth. And what you want to do is create abrasions such as listed and shown here. And what this does is that it allows you not only to look at the exfoliated cells, but also samples some of the epithelium, and the brushings that you get here resembles forceps biopsies to a certain extent. So here's how you do it. You want to create some bleeding and obtain deeper tissues through the epithelium. The important thing, what helps improve the diagnosis of dysplasia here, is that they use an artificial neural network computer. And the computer looks at all the brushings and then presents to the cytopathologist the 200 most abnormal cells by using a complicated algorithm which was actually developed by the Israeli army to look at the pictures from the drones to see what was true enemy versus pseudo enemy, and that's exactly how this artificial neural network used. And these are examples of high-grade dysplasia cells which can be seen through this technique, and there is currently an ongoing randomized tandem control study to see whether this would be helpful in replacing 4-quadrant biopsies every 2 centimeters to do that. To better diagnose dysplasia and characterize lesions, you can use narrowband imaging or virtual chromoendoscopy with near focus as shown here. This is a Paris 2A lesion. What this helps you define is shows you that the lesion is not just here, but extends from the 12 o'clock position more to the 3 o'clock, 4 o'clock position with more abnormal surface architecture than is shown by white light endoscopy, and this may help you better characterize Barrett's lesions as well. If you want to look at cells real time, you can look at confocal endomicroscopy. This is an example of non-dysplastic Barrett's esophagus, and what you see here are the nicely arranged cells of columnar epithelium. You can see the fluorescein, which is in the blood vessels, and you can use this either through an endoscope or more commonly through a probe which is passed through the channel of the endoscope. This is an example of cancer, and what you see in this situation is that there is leakage of fluorescein outside of the blood vessels. The normal architecture of the glands is lost here, and you can see large goblet cells which are irregularly shaped, and this is an example of esophageal adenocarcinoma in Barrett's esophagus. Are there actual studies to show that this imaging techniques can help improve the diagnosis? And I'll just show you one example which we published last year in Gut, and this was an RCT that we performed along with Jacques and his group in Amsterdam and Rob Hawes in MUSC. And what we did is that we did a crossover trial in which patients with Barrett's esophagus got high-definition white light endoscopy with 4-quadrant biopsies every 2 centimeters. And then the same patient crossed over, acting as his or her own control, and then we performed just electronic chromoendoscopy with NBI and used targeted biopsies only. So this is the study design that we used. And when we looked at the findings, comparing narrowband with targeted biopsies on the left, what we found that we were able to pick up significantly more areas of dysplasia. However, when we looked at high-grade and cancer, this was not statistically significant. The most important thing was that we were able to do this by reducing our number of biopsies in half by using NBI with targeted biopsies compared to high-definition white light endoscopy with 4-quadrant biopsies every 2 centimeters. So what's clear is that we can do targeted biopsies, whether it's by using just high-definition white light endoscopy or by using electronic chromoendoscopy. We will hear about endoscopic therapy, and I think it's important to recognize that you can get some tissue beneath the Barrett's squamous mucosa, which is now ablated. Here's an example of an EMR specimen from a patient who had undergone successful ablation in a trial And what we find is adenocarcinoma here below the squamous tissue. And this will obviously not be visible on standard white light endoscopy or surface imaging because it's below the surface tissue. So one technique which is being currently studied is this issue of volumetric laser endomicroscopy, or VLE. What this does is that it gives you a sector scanning of 6 centimeters of the esophagus. You can flay open the esophagus and look at it in a longitudinal section like this. This is in the proximal esophagus on the top, and the bottom is the distal esophagus, and this is the laser light which scans the entire 360 degrees. And this offers the advantage of you being able to look at from the proximal to the distal or look at it in a 360-degree angle. These are the images of squamous mucosa, what it looks like on this 3D OCT. And these are images of Barrett's mucosa. And you can see that this is the surface epithelium on the top. And you can start looking at glandular epithelium, which is in the submucosa below the surface epithelium. And we presented some preliminary data last year that this is a feasible technique. The actual application of this to diagnose subsquamous buried glands still remains to be seen, but it does offer the hope that you can look at squamous mucosa below that. How about just looking carefully instead of these techniques? And here is an endoscopic image of a patient referred to us with low-grade dysplasia. And what was missed by the endoscopist was this, again, invasive adenocarcinoma, which is a Paris 2A lesion. Nowhere in the endoscopy report was this lesion mentioned, and nor were the biopsies taken from it because they probably sampled some other areas away from this area, and an endoscopic resection of this revealed that this was an invasive adenocarcinoma. We've published some results. This is Neil's study in GIE a few years ago, which shows that the more time you spend in the esophagus, very similar to the colonic withdrawal time, as Jerry's shown very nicely in his studies, that the more time you spend, the more likely you are to find more areas. And you can see that as the BIT, or the Barrett's inspection time, increases from the left to the right, the more likely you are to find areas of high-grade dysplasia and adenocarcinoma. And this is just a video from our BOAN project, which was supported initially by AstraZeneca and now by Covidian, which we are looking at, and I'm happy to see Michael's here and Jacques here from our group, that we can look at the subtle lesions of early adenocarcinoma in Barrett's esophagus and be able to then map these lesions with the help of a specialized software that Bjorn, one of our technicians who are working with us on this project, has created. So here's a video that you can look at. You can see that this is the area on the top, and an endoscopist sitting in Kansas City can look at this online on a web-based program and can map this area and say that, well, here's the early adenocarcinoma in Barrett's esophagus. The software will then calculate the surface area for you. And somebody else in Amsterdam, for example, can look at this area also through a web-based server, look at it, and we feel that this is going to be a very important educational tool. Our working group is in the process of just validating the software as well as looking at this internally, and then several of you experts in the audience will be asked to participate in this project and help do that. So finally, to conclude, what I've shown you is that endoscopy plays an important role in making a diagnosis. So be careful, look at the landmarks, characterize that, spend time looking at the subtle areas within the esophagus and making a diagnosis of dysplasia and cancer. And then target biopsies will probably give you the highest yield for making a diagnosis of neoplasia in Barrett's esophagus. Thank you very much for your attention.
Thank you very much, Professor Sharma. I'll pass over to my co-chairman, Professor Neuhaut.
So your question, if we still need the pathologist, but now we very much appreciate that Michael Feed, director of the Institute of Pathology of Bayreuth, will answer this question about the role of the pathologist in the diagnosis of esophageal dysplasia and cancer.